Hi, everybody on Surgeon. Welcome. It's a pleasure for me to introduce three outstanding surgeons and friends of mine who have a lot of diverse expertise and experience in their practice fields. Hopefully, they'll share some of their understanding and help you to choose a career trajectory that best fits you. First we have Dr. Don Yoon, who's an amazing general and colorectal surgeon who leads a community practice in Fullerton, California. Don completed his colorectal surgery fellowship at the University of Massachusetts in 2023 and his general surgery residency at USC. I think you'll find a common theme that a lot of everybody here has some connection to USC. His practice is notable for its range of acute care general surgery cases and complex colorectal problems. He includes robotic and transanal approaches in his repertoire. Outside of his clinical work, he really enjoys his life and family of five, including three young children, the youngest being 5 months old. Next, we have Dr. Sarah Choi. She's a staff colorectal surgeon and assistant professor of clinical surgery at Keck School of Medicine at USC. She earned her medical degree from Wayne State University and completed her general surgery residency at the Cleveland Clinic. This was followed by a fellowship in colorectal surgery at, you guessed it, Keck Medicine at Los Angeles General, where she now serves as the Colorectal Surgery Division Quality Officer. And she's actively involved in the ASCRS and the Association of Women Surgeons, and her clinical interests span across a wide range of colorectal conditions, which she specializes in minimally invasive techniques, including robot and laparoscopic surgery. And last but not least, we're joined by Andrea Mariato. She's a board certified colorectal surgeon practicing in Miami, Florida with GastroHealth. A South Florida native, Dr. Mariato graduated summa cum laude from the University of Miami, where she completed a combined BSMD program. She trained in general surgery at Boston University Medical Center and completed her colorectal fellowship at USC also. So Dr. Mariato provides expert care in in a diverse community focusing exclusively on colorectal surgery for a largely Spanish-speaking population in Miami. And most importantly, she just got engaged in Zion, so congratulations to her. We look forward to the wealth of experience and insight that we'll hear today, and I'll turn the floor over to my co-hosts and our interviewees. So thanks for coming. It's good to see you all.
Thanks for having us.
See you too. Thanks for having us.
Thank you.
So I was thinking we would start, because it's kind of an open discussion, maybe with Sarah, and we can have you describe what your typical day is in your job, and then kind of a little bit of description about what your job entails, and we can move on from there.
Okay. I guess day to day it was a little bit different, but in general, I would say I have about two either half days or full days of clinic. I go to three different hospitals. So the main campus as well as two satellite offices. So I do have clinic at all three locations. So every week I'm going to a different location, but either 1 or 2 days of clinic during the week. And then I would say I do scopes, colonoscopies 1 day a week. And that is the most consistent thing about my schedule. And then the other 2 days are kind of filled with either anorectal or abdominal cases at all three locations. It really just depends on, I think because I'm just getting started, I don't necessarily have block time. So it depends on my colleagues and their open block time or open elective time for me to get scheduled into cases. So I would say my week looks different every week, but in general, that's kind of how my schedule looks like.
Great, thanks. So we'll kind of shift a little bit to the community practice setting. So Don, do you want to do the same?
Yeah, sure. It's funny that Sarah says that. My week is exactly like what she's saying. It varies week to week at the moment. I'm in a kind of an interesting moment at this time because my current colorectal partner is out on maternity leave, and there's one colorectal senior partner who's kind of on the verge of retiring. So there's a lot of flux and movement and changes. I'm taking on a lot of my current partner's, volume, and as Jordan mentioned, I also take general surgery call as well. So it's pretty variable. I do have block times that are consistent, but I'm also taking my partner's block times when I can, switching offices. But all in all, it's pretty consistent in the sense that I have some degree of ownership and ability to change my schedule as I need to, fit different cases in where I can. But on the days that I'm not operating, typically, obviously, I'm in clinic pretty much for the most of the day. In the outpatient setting, I do strictly colorectal, but there is significant inpatient general surgery volume that, despite me focusing 100% elective colorectal, practice, I would say my general to colorectal caseload would be about 40-60% because of the inpatient call, volume that I have to take on. That's generally it is a little bit in flux, but yeah, it's high volume. It keeps me busy for sure. I do go to a single hospital. Just that's the difference I wanted to mention. My practice is based on one hospital. It's a 320 bed community hospital in Fullerton, Southern California. And my office is right across the street, which makes it a lot easier to kind of deal with both elective, outpatient and inpatient stuff within that small area. I also do scopes as well, and that typically happens twice a month, and then, as needed in addition to all of that.
Great. And Andrea is more in the private practice setting, so I'll ask her kind of to do the same.
Don, are you hospital employed?
Group practice, but it's a large multi-specialty group involving 350 physicians, a vast majority of whom are primary care actually. But they do employ a significant amount of subspecialists, including general surgery, others, surgical specialties, GI, etc.
Gotcha. So I am in private practice, although it's within a private equity group, so not straight private practice. I'm in a group of, when I joined, I was the fifth colorectal surgeon. Since then, one retired, so there's 4 of us. I have 2 full days of clinic and then 3 days of operating, 2 of which are developed block time, one which kind of shifts between a scope day and block time. Hospitals really, because they're sort of catered to the private practice setting, they're good about either giving me 2 rooms or jumping me between rooms and the endoscopy suite. So I don't have strictly like just endoscopy days or just colonoscopy or anorectal days. It's kind of all mixed together. I do cover, so I'm at a different hospital every day almost. We cover up to 5 hospitals. Really 4 are the main ones that we have patients at, and there's 4 of us. So at any one time, there's usually somebody at each of the hospitals, but there is quite a bit of rounding involved. If one of us is in clinic, then whoever's done first with cases sort of picks up the rounding. We don't have any mid-levels or anything like that. And then there was something else that I was going to mention and I've forgotten now. And it's all colorectal. So my call is strictly just colorectal consults through the ED or through the hospital. Yeah.
Great. Actually, that's a good question for Don and Sarah. What is your experience with APPs at your institutions, and do you feel like that's typical for the job types that you have?
So I have a lot of APP support, I would say. I have a team of residents and fellows for the inpatient side. So rounding, like typical patient care is mostly done by them, which is great. And then we have a PA also just purely for inpatient care. We are a group of 6 colorectal surgeons purely at Keck, and then there's 3 of us at the county. So it's a little bit different, but I'm mostly on the Keck side, so I'm going to speak for the Keck side. So there's 6 colorectal surgeons, and so our inpatient load is handled by at least one inpatient PA, so resident fellows. And then in my clinical practice as well, I do have a PA that handles kind of my patient phone calls, at least during office hours. So she will kind of handle more like refilling prescriptions, answering questions, post-op care, things like that. And then, of course, she will forward any questions that I will need to answer or address or call the patients back for. But I do have good support.
In my practice, I have some PA support. It's in community practice, you kind of do everything. You're back to being an intern. You're writing discharge summaries. You're writing H&Ps, putting in orders in the mornings, and following up on stuff. And it's not as daunting as it sounds, to be honest, because you've done all this and you're a total expert in how to navigate the hospital system at this point. And you're also super efficient as well. And the hospital system in the community setting also acknowledges that physicians are, their main responsibility is not necessarily to put in the orders or, to put, to kind of go through the logistics. The nurses would do they would go out of their way to kind of help out, and as long as I get a verbal order, they'd be happy to happy to put in the order and work with case management, this and that. And so the system is set up in which it really helps to facilitate my practice. With that said, I do have a physician assistant who is shared amongst three colorectal surgeons at this time, and she does both inpatient and outpatient. And between the three of us, obviously her time is kind of split. I don't always get to have her in my operating room or able to round with her. But in the operating room, we do have RNFAs, so our registered nurse first assist, who basically I would say are that low in terms of technical abilities, are that of maybe PGY3 or so. So pretty good, and good enough support for me to be able to do pretty much everything I need to do. A lot of my practice is also robotic, and I do most of my stuff kind of all robotic, intracorporeal and so forth, where I don't really need another assist per se. So that's kind of also changed how I practice, as I've kind of grown during this year of practice.
A follow-up question with that, when you don't have, well, did you say that you don't have an assist when you do robotic surgery?
No, we do. We do need a bedside assist, an RNFA or a PA or another physician. But in general, even if I can't get a PA, I'm guaranteed to have an RNFA because I can't do the case without one.
Right. Okay. Maybe we can move on and talk about generally what you find to be like a benefit of your practice setting, and then maybe a disadvantage for those of us who are considering kind of what avenue to try to pursue. You can start with, I guess Don can go again.
Sure.
Yeah.
A benefit of what I do is it's purely clinical. It's high volume clinical. So I spend all of my energy and my time taking care of patients directly. There's no other responsibilities administration wise or academic per se. There's no research pressure. Really, I'm able to spend all of my time focusing on, what I really enjoy doing is taking care of patients and also operating. And the community setting is interesting, and I've never really experienced it before coming out of training because all I've known is academic settings. But it's a setting in which you recognize the resources you have around you, and kind of you're able to pick and choose what your limits are to some degree in terms of case complexity and volume, what you're willing to accept and what you're willing to transfer. And it's one of those things that have allowed me to kind of expand what I feel like I can handle and kind of, take on what I feel like I can. And it gives you that freedom to be able to choose. And for me, I feel very lucky in that I do have very supportive colleagues, both in general surgery and in colorectal surgery. It's not like an academic setting where we have, 5 to 10 colorectal surgeons who are, able to help out. But even without having one or two very supportive colleagues really does make a huge difference. And so I think that's one real benefit that I feel like I didn't understand until I started practice here. One thing I do obviously miss, and I was actually thinking about this recently too, is working with trainees. You don't really you don't have, you're not plugged into that academic setting where you're constantly working with trainees and involved in teaching. And because you don't have a large subspecialty group supporting you, you don't oftentimes have the opportunities to engage in more academic discussions and, research and all of that. Obviously, I still routinely talk to my colleagues about cases that I do, and it's pretty much on a daily basis that we always talk to each other about these cases. But as far as academic, aspect of things, I do miss a lot of that community aspect. There's some degree of feeling a little bit in, practicing in isolation sometimes in community. And I do think because of that, participating in a societal kind of group really is helpful.
I would echo that in private practice. It definitely, when you get out, you're used to having a whole posse with you, and then it's just you. And you're like, this is really cool. I get to do all the cases myself. And then you realize, like, I haven't really even talked to anybody in all week. So it definitely underscores the importance of sort of your interpersonal relationships at work and making friends with the other surgeons. Like, I do strictly colorectal, but there are other colorectal surgeons who are hired through the hospital system. So we do routinely talk about cases, but not to the degree that you'd be doing in an academic setting where you have case conference and where you're just, the volume of cases that you're talking through. Because I am in a big metropolitan area in Miami, there's multiple different cancer centers. So there's a cancer center that's associated with the University of Miami, but there's also a cancer center within my hospital system, and they do have tumor board. And so we do still have sort of that interaction with the oncologists and radonc and, everybody, especially for the rectal cancer cases. The patients who can't go within that hospital system, and I do practice at one other hospital that's HCA, so it's sort of a different hospital system. They don't have an established tumor board or cancer center, and those patients, it's just a little harder because it takes a lot more coordinating on your part outpatient. Like you see them and you're like, okay, let me find an oncologist that's covered by your insurance. And I never had to think about insurance. And now I have to be like, okay, well, where can they go? And can they go to the University of Miami or can they not? And especially starting out, what was new for me was there's no way to page people. Everyone just has everyone's phone number. And also in the community, how do you get in touch with these people? Then you're on this phone tree trying to get to their office to make sure that patients follow through and they got your referral and what they think, and are they doing what you intend them to do? Are they getting long course, or are they doing TNT, or so it does involve a little bit more coordinating on your end, and it depends on the support that you have in your office. So you end up relying a lot more on your coordinators and your medical assistants more than I ever did in training. One of the pluses is I get to sort of do whatever I want in terms of cases and variety and what I want to focus in on. And the hospital wants you to bring cases to them. So they want to be able to offer the robot to you if that's something you want. If you want a specific gel point mini, they're like, sure, we'll order it, no problem. Tam is on the robot. Yeah, of course. I'll get the rep in for you for this mesh that you want. I haven't done robotic Hartmann's procedures, but I have done robotic Hartmann's reversals. And I can add on a case. Sure, it may not go exactly when I add it on, but it'll go by 4 or 5 p.m. that day, and they can have a robot available for me because they have 5 robots in a single hospital. So that part has been really nice. My practice is entirely robotic for the abdominal cases, unless I convert to laparoscopic or if it's a lab colostomy creation or something. But the challenges definitely are that the infrastructure is not there, and you don't have residents, you don't have colleagues that you're running into all the time, maybe your colleagues that are at a different hospital. The way that my hospital is set up, our first assists are actually, because we're in Miami and there's a lot of Latin American surgeons who come to this country and then don't get their certification and get their MD to become independent surgeons, they are the first assist. So sometimes I'm working with a general surgeon from Venezuela who's the first assist. Sometimes I'm working with an orthopedic surgeon who's the first assist. So there's varying skill levels there. But Dawn, when I use the robot, they suction and then they help me do the anastomosis, but that's basically it. You have much more control.
Right.
Yeah, so I guess I'm the opposite end of things compared to the other two. I did my fellowship at USC, so obviously for me, the biggest thing kept keeping me there was the people. I love my colleagues, and I think they're great people, and I think it's the extrovert in me, but having colleagues around you, mentors around you, having weekly conferences. And then also even with outside your department, when I go scope, I see my GI colleagues in the same room. So we'll talk about cases or talk about patients and refer to each other. So I think that has been nice, especially starting out, that I don't have to necessarily focus on going outside of my hospital system to seek referrals. I still did, start off with some marketing and making sure that the outside referral system knows who I am and communicates with them, and I communicate with them and things like that. But I think having to just focus on my clinical practice because of our big support system, because I have surgical schedulers and scope schedulers and billers and coders, and I don't have to worry about anything insurance related either. If a patient comes, I can order what I need. I trust that my coordinators will get it approved and then they'll get it done. And or referrals are done as well without me really having to focus on that. So I have been able to just focus, purely on my clinical practice, what I would do for the patient. So that has been nice. And then I think, teaching residents and trainees is another aspect of, obviously a big aspect of academic surgery that I enjoy. It's really nice having, and we have fellows too. So and they are very engaged and obviously want to be there and want to learn. So teaching fellows it's been a good experience. And then I teach residents, and some of them like are on the border of going into colorectal or not. So that's exciting as well as medical students. I do think we do have some more administrative roles in the academic setting. Like I'm doing the quality, I'm part of the advisory committee for the hospital. I do medical student lectures, didactic lectures for fellows, residents, like mock orals. So there's a lot of opportunities to teach, get involved, which is good. But I think when you're starting out, it can be a little bit overwhelming if you don't know how to say no, which I haven't learned how to do yet. And then I think the disadvantage is probably, I don't know. I mean, probably don't get paid as much as, some of my colleagues, and or like there's like not really a big like bonus structure or anything. So like nothing I guess I do is really financially driven, which is good. I don't have the pressure to do that either. So that's nice. And then, yeah, some of the administrative roles. And then I think when you're starting out, sometimes if you're not kind of confident in your like how you want to do things in the operating room, first year, it's like a big transition to become your own surgeon, like figure out what you want to do, what staplers you want to do, what approach you want to use. But you have residents and fellows that are, depending on you to teach them as well. So having to pass this case on to the resident or the fellow, even though maybe you want to do it. I think that I don't think it's a disadvantage, but it's like a learning curve when you're starting out in academic surgery.
Yeah. That was going to be a follow-up question from the Surgeon chat. Was Felice De Stefano was asking kind of what your experience was as relatively junior attendings working with residents in the early years. And then I was going to kind of parlay that too as how was your experience? How did you balance the need for continuing your growth as a surgeon with continuing the like academic teaching for people who are there to learn, like residents or fellows? But I feel like that was very well covered. So for a follow-up question is, in each of your practice settings, what is the referral pattern, the typical referral pattern? And how do you feel like this is good or bad? So I guess let's reverse, and actually we'll start with Sarah again, and we'll go to Andre and then Don.
Okay. I think because we're part of a big hospital system, obviously our GI colleagues and or our maybe primary care colleagues will refer within the system. So that has been kind of an easier transition. That being said, I think there are a lot of other outside our hospital system physicians who refer more complex care to the, tertiary centers. So that I guess is sometimes difficult, especially when you're starting out. But the good thing is that obviously you have a big department, you have mentors. So it's like very easy for me to, text or call my partners and ask them a question. And so that is advancing my own growth. So yeah, there are some challenges and the like fear of like, oh my gosh, what if I can't take care of this very complex issue? But you have a lot of help. So yeah, that has been my experience.
I've already sent a patient to Shin
Oh,
earlier
really?
this year.
I think he told me about it too. He's like, yeah, I did this case. He gets excited. He tells me all about his like cool
Did you
cases. So
did you get that referral and you're like, this is right up Dr. Shin's alley?
Yeah, I was like, appendiceal mucinous, this goes to Shin.
Yep,
It's like a 10 centimeter mass.
no question.
So my group is called Gastro Health. It's actually a large group, like umbrella organization for a lot of GI practices. And then I'm part of the one colorectal group of the four of us now. So a lot of my referrals come internally through them. However, a little bit more towards like the private practice aspect is they could refer to anybody. Like there's a lot of colorectal surgeons in the area, and I have other partners. So you sort of get to know a few GIs who then just text you directly referrals. I also get referrals from the GYN oncologists in the area that I've worked with, or just the gynecologists who have seen me do some of the robotic rectopexy stuff and they're interested. And then our hospital puts together some networking events. So I went to a few of those and I get a few primary care referrals and things like that. And then honestly, when you're in private practice, like patients definitely start talking about you and know about you. And when they're very happy, I'm like, write me a review. It really helps. Like you thought I was too young to do this, but like it went well. So I definitely had a few patients who were like, oh, I Googled you. Like, yeah, I picked you. Or patients who are very happy after SNS and like tell like their entire center, like of everybody who has fecal incontinence, to come to me. So just be careful
Yeah.
with what you ask for. But so far it's been great. But for sure, it's, the interpersonal relationships that you have and you build when you're in the hospital and you meet different providers from different specialties as well.
Yeah.
Yeah, I definitely echo that. In the community setting, for me, we have a large multi-specialty medical group, primarily, significant amount of primary care. So we get a lot of in-network or within group referrals. We have a large, very busy GI group with it, as part of our group who also, continually feeds referral to us. But outside of that, St. Jude is under a larger healthcare network called Providence. And so within Providence also, they end up sending, from other smaller centers, they end up sending patients to us. And that's how we get some of them more complicated referrals as well. And then there's smattering of true private practice GI groups, true private practice, primary care doctors who end up somehow hearing about us, and we've either through patients or through other networking events who end up kind of referring patients to us. But I think, to Andrea's point, really at the end of the day, if you have really good rapport with patients and patients are very satisfied with their encounters with you, that's kind of the best, I think, way that your name is going to spread, either through reviews or just word of mouth. And if I've had plenty of patients who said, "Oh, you treated my my uncle's this and that," and I'm like, "Oh, that's your uncle, okay," and it's probably one of the faster ways to kind of end up getting a lot more referrals.
Let me
And
ask you
closing
a
the
quick
loop,
question.
that was
Oh,
something that I
sorry.
never had to do before, or I guess I didn't
Yeah.
really do. But now all the time, like I'm like, oh, this was the path. Like, thanks for sending them, and talk to the oncologist, and same thing, like constant communication.
Right.
So Don, you mentioned that your practice is 60/40, and I was wondering, is that typical for a community practice or in a community hospital setting? And then if so, does that mean that if you choose to be 60/40, are you locked into that as part of your contract? Just if you wouldn't mind explaining kind of how
Yeah,
that.
that's a good question. It's definitely not the only way, and there are lots of different practice proportions. Like Andrea, you could focus on 100% colorectal and not take any general surgery call, have to deal with any of the general surgery volume. There are other practices where you have to do one-to-one, or you're really a general surgeon, maybe taking a little bit of colorectal. So it really varies depending on hospital systems and what they need. In our practice, again, my practice is based in this one community hospital, and we have 6 surgeons who take call, basically 5 surgeons right now who take call. So we end up having essentially 1 in 5 weekdays and 1 in 5 weekends that we end up taking call. And that's just the way that this system worked. And that's going to change as we potentially get new, additional general surgeons, and as other surgeons retire. Things are kind of in a flux. My ideal was 20/80, that I would do 20% general surgery and do 80% colorectal, so predominantly colorectal. I didn't realize how busy the general surgery calls are here, so it ended up becoming more like 40/60, but I do enjoy general surgery as a whole, and I do think it has really sharpened my operative skills to be able to take care of some of those things. And it's nice to see some of the colorectal skills that I have, work really well for the general surgery cases, and vice versa. Some of the general surgery cases that have really sharpened my skills have helped my colorectal cases as well. So as a whole, I think it's kind of only helped me in terms of sharpening my skills. But certainly that's not the only, way you could, that practice is. It depends on the systems and the hospitals and what they need.
Something that I didn't consider when I was looking into different practice environments is what happens if you change practices. And so I know that hospitals want to see a case log, and they want to know that if you're coming from, wherever you're practicing and maybe going to a center that receives traumas, for example, but it's been 5 or 10 years since you in residency did any sort of trauma cases or did a lap chole. I don't know. It may be a little bit more difficult to move from 100% colorectal to then practicing general surgery and some colorectal, just based on, where you end up going and switching jobs. And a lot of people switch jobs in the first 2 years. So just, you don't have to get it 100% right. Just putting that out there as well.
That was actually kind of one of the questions I was going to ask is, we are so early in fellowship, we're only 2 months in, but because it's such a quick year, I'm sure people will start looking for jobs soon. And what do you wish you knew when you were kind of in our position, or what kinds of questions do you wish someone had said, hey, is this really important to ask or to think about? And what advice would you give to kind of your younger self?
Do you guys still have a career course?
Yeah.
Yep,
I
we're
found
gone
that
a few
super
months.
helpful because multiple lectures touch upon that a little bit. In retrospect, everyone, a few things. So first of all, everyone's going to paint you a perfect picture when you're interviewing, and you're going to kind of forget the things that you had on your checklist. So my checklist was like, make sure I have good support, make sure I have good partners. Actually, good partners was like the top. And I have great partners. Like, I have no regrets. I have a good mix of seniority and experience, and they're always willing to come in. And even though it's private practice, like, it's not all about like RVUs and you eat what you kill and all that stuff. So that part is great. But I kind of forgot along the way, like, I would like some support because I am doing all of the orders, discharge summaries, like following up on things, rounding at the end of the day. And I do a lot of driving. I didn't think that it would bother me that much, but some days I'm driving and the hospitals are 30 to 45 minutes away, and I'm rounding in a hospital, then I'm operating somewhere else, I'm doing scope somewhere else, and then maybe I'll see like 2 patients, stragglers somewhere else. So like in the beginning, I wasn't as clinically busy, so my driving time was maybe 3 hours a day in total. Now I'm like at one place, I have a full operative day, I can't do all the rounding, so we split it a little bit more evenly. The other thing is I didn't realize how much of a push there would be on productivity and on how you get paid being in a private practice setting, and I never really had to think about that. And now it's like, oh, well, if you do this in the office, it pays so much more, but then you can't see that many patients in the office. So then like your census kind of goes down, and like you have to kind of balance this, like, how productive am I being, but I feel rushed. Thankfully, I don't feel rushed by the hospital, but they're also like, okay, we're giving you a block and you're not filling it. So like, we might take away your block, and all these little nuances that I think are, I don't know, Sarah can comment on this, maybe less present in academic practice. And when you're hospital employed, like, I see some of the general surgeons, they're just kind of like, well, that was my day, turnover sucked, but like, I'm just employed. Versus for me, it's like, okay, turnover sucked, but like, now what are my RVUs for this week going to be? And we get like a breakdown of like, this is how many scopes you did this week, this is how many minor cases, this is how many major cases, here's like your trajectory for the year. And like, it all depends on collections. So you might be doing your job great, and then your billers aren't doing a great job. And so at the end of the day, like, it doesn't matter that you did all that work. It's sort of like the bottom line is the bottom line. And so if you're thinking of going into private practice or a private group, just having very clear like what that looks like, and when your productivity kind of like when you have to meet certain metrics. I'm on one of the committees, ASCRS, for like private practice physicians, and a big thing has been just contracts with insurances, and they don't want to give good contracts to small groups. So you may be doing the same case that somebody's doing who's hospital employed, and they get paid 1.2% of what Medicare reimburses, and you might be getting 0.8%. So you're doing all this work, and your work just is valued less because you don't have good contracts. So it's like a lot more things that you realize, like, oh, there's like so many work, like, moving parts in practice.
Yeah, I guess I don't worry about any of the financial things at all. Everything is, the patients are usually approved through their insurance to come see me. And then if they need any follow-up appointments or any referrals or any imaging, I have coordinators that are pre-authing and doing peer-to-peers and everything on the back end. So I don't have to worry about that at all. Mostly I'm worrying about what I want to do for the patient, how am I gonna get it done without having to worry about those things. So that has really been nice. I think we do have a bonus system, but really I think it was collections, but I heard that they're going to change it to like a RVU based model as well. Probably my thought is that my first year I don't get a bonus, so for me it didn't even matter. But I think they're trying to move it to RVU based model, and they're going to make this RVU probably pretty high, so that the majority probably will not get a bonus, and so we'll just go on their salary, and then only the like very high earners will probably get that bonus. So I think in terms of academic surgery, you're pretty much salaried, with maybe a bonus if, if you're a very, very high productive surgeon, high earner, and that will probably be not many of us in general.
When you're academic and you take positions like the quality chair, and then you hold different academic positions outside of the hospital, are you compensated for that, or are you no? Okay.
No,
Are you at 1.0 FTE?
I don't even
Or
know.
like, does it, okay. I do know that if you do research or you're like involved in teaching, they may lower your FTE goals so that your RVUs are not, it adjusts.
I
Right.
think they're still working on the whole, I think right now it's still like a collections base, but they are working to do this whole RVU based model. So we'll see how it works. And then I think at USC, there are like different tracks. Like, so obviously the next step would be getting promoted to associate professor from assistant professor. So I guess those are the things that you start having to, you have to prepare for and have to think about every little lecture you do, or if you have like med students or undergrads shadowing you, you have to make sure, you have their names down. So it's like you have to build up your resume so that you can get promoted. And that process takes anywhere from like 4 to 7 years. So those are things that you have to start thinking about as well as you collect all these things. But yeah, I guess I haven't. And then research and all these things. Oh, so I was saying there's different tracks. I think there's like, you can get promoted for like a research heavy track. And then there's one that I think is like a clinician educator track as well. So if you're not really doing much clinical or basic science research, you still have the opportunity to get promoted through a clinical track.
I'm kind of in the in between, I would say. I think and this is again something that I really had no real clue about until I came in. And I think one of the pluses of being in a larger group practice with over 300 physicians is there is definitely power in number. And you, as part of our group works with, again, this network called Providence, which it's a very interesting layout the way they have it. But basically, we have three pieces. We have the medical group, which is physicians only. We have Providence, who provides us all the infrastructures in the outpatient setting, all the medical assist, the office managers, office space, all the supplies, etc. And then we have the hospital, which is a separate entity with which we have exclusive contract with. And so we have this three triad kind of symbiotic relationship, none of which could survive by themselves. And they all kind of help each other. And so we as a group deal with insurance on a regular basis, but I never personally deal with it myself because the group is able to negotiate, the group board and the leadership are able to negotiate with the insurance on our behalf. And we have a lot of leverage because of the patients that we serve in our community through those resources, the hospital as well as Providence, elective outpatient structure. So I think one thing that Andrea was mentioning is kind of understanding a little bit more about your pay structure is very helpful to get a sense of that. Like, what is it truly based on? I've heard of, when I was interviewing for jobs, much smaller private practice groups where you're joining just a few surgeons, where they would basically out of their pockets supply you with 1 to 2 years of bridging salary so that you can build up your practice, after which you kind of have to pay them back. And there's like all these weird and strange dynamics between, groups that you may be joining. And whereas my group is truly, it is salary based at the moment, but there is an RVU structure, that bonus structure with a very reasonable RVU goal in the first 2 years. And then after that, when we become part of what we call shareholder as part of the group, that changes to be more, RVU based, but also with increased compensation in general. And there's a lot of other quality metrics that they look for as well, that they base our bonuses on. But ultimately, for me, I think I feel grateful to not have to think about a lot of that and really just kind of focus on just clinical practice. My MAs and we, being a larger healthcare network, we're able to have a lot of insurance authorization. My medical assists and office staff are able to help me in a lot of those logistical, barriers, prior authorizations, and etc. But we do have a lot of leverage as a group, and I think that's a big plus that I had no idea until I joined this practice. One thing I want to mention is, Andrea had touched upon this too, is having a good group of colleagues, I think and if you can find a mentor, even better, I think is an unbelievable resource that sometimes overlooked. I've looked at jobs where I would be, joining a good quote unquote group, but that covers multiple hospitals, but I would be stationed at a satellite hospital by myself. And really, the other colorectal surgeons would come down once in a while to help me, but I would really be in isolation. I could give them a call, but it's not the same in which I can, if their office is next to me and I can talk to them about cases on a daily basis. I think having support, especially as you start out, is an unbelievable resource. I think I can't overstate how important it is. It's really, really hard, and I've been told this too. It's really hard to start off by yourself. It really, really is. Not impossible, but very hard.
Yeah.
Yes, sorry, I forgot to answer the original question. Yes, so no, I think the number one important thing, yes, when joining a practice is again the people, your partners, having mentors. And then I think you really just have to be true to yourself and what you're looking for in your personal life as well, right? For me, location, well, I did my fellowship, so I knew the people were great, so I had that. But location was also going to be very important because, it's where my friends or family are, or your significant others, or your, I think you have to look beyond just the job itself and what's going to make you happy and the things that you need in your personal life. And I think it could be location, it could be like the job style. Yeah, it could be if you're introverted, maybe, you don't want to have so much interactions with so many people in a day. So I think you just have to really know yourself and kind of what you're looking for and what's important to you. And that will help you also figure out where and what kind of job you're going to be happy at.
Yeah.
And whatever number they give you for salary, I had this when I was interviewing. Some jobs looked great, but then you had to keep up a certain productivity to keep that amount, or their cost of living was so high that it sort of all leveled out. And you have to consider multiple different factors. And then also it's good to have clear, like, what is the next step? Like, how do you become partner, or how do you get involved? Like, can you get involved at ancillaries? How do you get promoted? How do you become professor? Like, all of those things are good to just kind of have like a good understanding of how that works. Like, I don't think in my contract anywhere it says what RVU goal I have, and I'm actually still employed, so it doesn't really ever run out. I recently found out that my contract just auto renews, and it's sort of up to me to renegotiate it. So nothing is really tied to productivity, which is a little strange, but there's a pressure. And I know that my office interacts a lot with the insurance companies, and I actually don't. So yeah.
Oh, and I think a tip that I would offer is if you know anybody that knows the person that left the practice, if you talk to them, I think that will give you a better understanding of the job, the people, and like maybe why they left, because they could have left for like nothing other than like personal reasons. But I think it offers a good idea of, or a good look into kind of what you should be expecting.
And then maybe there's some of you that are in a situation where you would be the first colorectal surgeon of a group, like a multi-specialty group. There's a lot that you take for granted, like what type of anoscope, what type of, like, do you have a FlexVig in the office, and like the actual OR instruments and supplies and the infrastructure. Like, do you have ostomy care? Do you have pelvic floor physical therapy? Do you have gynecologists who are used to help, like, handling pelvic floor prolapse? Like, a lot of that stuff that you don't, it's a lot. Not to discourage you, but make sure that you have a mentor, somebody who can help you establish that at a new hospital or a new system or in a new practice, and that you lead with that when you're signing your contract. So there's stuff in writing that, like, I need this for my office, with some of the advice that I got. Thankfully, I didn't walk into that setting, but having as much in your contract and like spelled out before you start as you can.
I have one last quick question. Thank you so much for spending your evening with us. But kind of going all the way back to the beginning, what resources would you recommend to even start looking for jobs?
I think for me, well, I think word of mouth is probably the the biggest way that are like the most common way people find jobs. Like either someone knows somebody that has a job opening or people make phone calls for you. Because some of the jobs are not necessarily posted, but are kind of unofficially filled and then posted. So word of mouth is probably very important. And then I think I did a Google job search like setting. So I actually still get those just to like see what's out there or see like what's going on. But there's like a Google search I did. And then of course the ASCRS website, there's like a job search posting on that website as well.
If you're tied to a particular location, I would just start messaging, like, for example, an academic practice, message the chair of that department or the chief of the division, just say, hey, like, I'm interested, here's my, just like open the door of communication, because you're still early on. And like Sarah said, a lot of times by the time the jobs get posted on the ASCRS website, it's because they have to get posted, but they've already sort of been filled. I actually found my job on the ASCRS website and they were still interviewing. But for a while after I interviewed and we were in negotiations, that job was still posted and there were still people inquiring about it. So sort of being on the other side of that, some of those are just a little old. I think I saw the same job on like Practice Link. I think that's another one of the job sites, but I got recommendations to look on Indeed, to look on, everywhere. I think ACS also has a job board.
Yeah, I think those job boards, people both in residency and fellowship, you just kind of have to use all of your network and maximize, and tap into their networks. Fellowship program directors are often very, very helpful. They know a lot of people. But one thing I will say is, as you look for jobs, sometimes you have this ideal of what kind of job you really are shooting for, and I think it's worth it to kind of explore other options, even for the sake of just kind of seeing what's out there, and not necessarily pigeonhole yourself to just one type of job. I think that's one thing I did early on that I wish I had expanded a little early on in the beginning, but it's helpful at the least even to just hear, oh, well, these are the other kind of types of jobs, and these are the reasons why I actually really wouldn't want this, but or you may consider these other types of jobs that are different from what you were initially thinking for other reasons. And it's helpful to be open-minded. You never really know where you're gonna end up. What I would say is somehow and I've been told this too, somehow it kind of works out. Somehow things somewhat fall into place, and you can never predict it in the way that it somehow happens. I would not have predicted that I would be here last year during this time. It was a couple months of agonizing decisions, but somehow it all worked out. And I think at the end of the day, it does. Just keep an open mind, keep an open door, explore all of your options. Don't be discouraged if you feel like there's nothing available based on what you want. And so it's a good thing to keep open doors.
To add on that, I don't think it's ever too early to start looking, but it's also not ever really too late. I have friends who the job, like nothing really fit, and they were like, I'm not going to pigeonhole myself into a 2-year contract for something that I know that I don't like. So they signed as late as July, August, September even. And there's some people who are probably finding their jobs as early as December. My co-fellow signed like in April. So just because fellowship is ending doesn't mean that is your deadline.
Yeah.
New stuff pops up all the time.
Yeah, I think I signed in April also, after my general surgery boards.
Great. Well, this was awesome. Thank you so much, guys. It's about 8 o'clock, so I think we'll wrap up. But, hopefully everyone listening has good luck finding jobs. I know it's kind of stressful, but keep your chin up. It'll happen for most of us, okay? Thanks, everybody.
Go to the career
Go to the
P.
career course. Yeah, I'll see you all at the career course.
Good
Thanks for your
luck.
time.
Good luck,
Bye,
guys.
Have a good one.